Hello, friends. Welcome. This is Steve Cross. It's so lovely of you to join us here for the UCL Institute of Healthcare Engineering's Science Showcase. We've assembled for you 1, 2, 3, 4, 5, 6, 7 of the most incredible minds in medicine, health, engineering, science, technology, and other nouns that are progressive and sound good and about the future. And they're going to tell you all about the wonderful work that they've been doing. And then there's some time for you to ask them some questions. So we're going to hear a talk from each of our 7 wonderful medical engineering people. And then they'll all come back together, and then I'll ask them all the questions that you've been asking all the way through. If you want to ask a question, the best way to do it is just to use the YouTube chat. You can type your questions into the YouTube chat, and then I can pull them over onto the screen. I mean, watch this. Pull question over as a comment for myself, and then boop, I can put your questions on the screen. So do post them in there, because then I can ask them directly to our wonderful speakers. But where have we got these wonderful speakers from? That's a very good question, and it's one that I can't answer. But I know someone who can, and that is the Institute of Healthcare Engineering's boss of all that is good and outward-looking, Georgie Cade. Hello, Georgie.
Thanks for the introduction, Steve.
Would you like to tell our wonderful audience all about who these people are?
I'd love to. Right, so thanks everyone for joining us today. The speakers you'll hear from this afternoon are our very wonderful Impact Fellows at UCL Institute of Healthcare Engineering. We've been working with them all year to train and build their skills in how to increase the impact of their research by engaging beyond university walls. So essentially that's things like policy engagement, media engagement, working with communities, publics, patients, media, science communications, which you'll hear about today. And we're really excited for you to get to know some of them a bit today and to hear a little bit more about their work. The other half of our cohort presented earlier this week on Tuesday, and the link to that talk is also up live on YouTube on this same Science Show Off channel. So do check that out as well if you didn't catch it on Tuesday. Finally, if this is the sort of thing that interests you at all, then we are opening up the Impact Fellowship cohort again for next year, and the applications for that will be going live in September. So keep your eyes peeled for that, and hopefully we'll see more of you. Perfect. Enjoy the talks.
Absolutely wonderful, Georgie. And one of the lovely things about today's talks is that we get to have a peek inside the houses of all of these great brains. And the first thing is, isn't Georgie great at plant care? Did you see the size of that plant next to Georgie and how healthy it looked? I mean, that's one of the great things about lockdown. Think of the wonderful things it's done for all of our plants. Now, I'm going to crack straight on with introducing people to talk to you. And so this is, it's a slightly odd thing, because this is a public event, right? It's not an academic event. It's not the sort of thing where I'm going to read out to you that is first degree at Oxford in the... Not going to do any of that. This is a real event. But a real event, when I introduce a speaker, the normal thing to do would be for you to applaud as they come up onto the stage. But there's no stage. There's only a screen, and there's no venue. There's only wherever you are now. There's your house or your work or wherever it is. So I think you should still applaud. So I'm going to introduce our first speaker. And what I'd like you all to do is applaud as they come onto the virtual stage to tell you all about their work. So wherever you are, would you please welcome onto your screens and into your houses the wonderful Matt Wilson.
Thanks, Steve. Good afternoon, everyone. My name's Matt, and I'm a PhD student at UCL. But I'm also a medical doctor, and specifically, I'm an anaesthetist. Many of you might know that anaesthetists look after people during their operations. We're the people with the good drugs who put you off to sleep and wake you up at the end. What you might not know is that we also spend a lot of time working in intensive care, where we use the same skills to look after the sickest patients in the hospital, and I'm focusing my PhD here. To start, 3 takeaway points about my work. Number 1, every day, doctors make thousands of small decisions about how to give patients different treatments. When we don't have clear evidence to guide these decisions, doctors will tend to apply treatments in slightly different ways, and we're really bad at learning what works and what doesn't. Point number 2, using the same computer systems that we currently have for providing patient care, I think we can learn from our decisions and improve. 3, there are loads of obstacles to doing this effectively, and it's going to require help from clinicians, patients, and you, the public. So first, let me take you back in time. Not very far, 16th of June, 2020, and scientists conducting the recovery trial released results which show conclusively that giving a cheap, commonly used steroid drug dramatically reduces your chances of dying from severe COVID-19 infection. This is a clear-cut, scientifically robust piece of evidence which immediately changes the practice of thousands of doctors across the country and indeed the world. In 3 months, these investigators had set up a trial, tested a drug, and found a positive result which saved lives, an amazing achievement. But contrast this with lots of other treatments commonly used in hospital, and the picture becomes less clear. In lots of cases, evidence for the benefit of treatments is mixed. Some studies show benefit, others show harm. This means that deciding what to do in these cases can become very difficult. This is especially true on intensive care, where many of the treatments we give as part of our routine care lack strong evidence about their effectiveness. Some decisions are really small, like replacing a patient's salt levels if they're low, but some of them are life-saving and life-changing, like deciding when is the best time to put someone with breathing difficulties on a ventilator, for example. So when as a doctor you come to a treatment decision where the evidence is not clear, we tend to use a combination of basic science knowledge and experience to make decisions. But everyone is different. So in these situations, when you start to study these treatment decisions, you see loads of variation in how doctors apply treatments to patients. Not everyone can be doing the right thing. Either this variation improves things, makes things worse, or makes no difference at all. But even more important than the outcome, I think, is what we learn from each of these decisions. And it turns out doctors are really terrible at learning. Okay, we do a lot of exams, so it's not that bad. But specifically, we're bad at learning what happens after we make individual treatment decisions. In some ways, we can be forgiven for this. It's hard to learn about the consequences of each decision when you're making hundreds every day. For context, when I assess a patient on intensive care, I might consider on average 2 treatment decisions per organ system. That's 2 decisions for your lungs, your heart, your kidneys, your liver, your skin, and so on. That's about 22 decisions per patient. Multiply that across 13 patients and repeat the process roughly twice every 12 hours, and you start to see why it's difficult to keep track of the effects of these decisions. So it's kind of impossible for individual doctors to keep track of this stuff. Humans just don't have the bandwidth. And this is where science comes in. In a stroke of genius, the NHS has recently discovered that computers have great memories. Don't laugh, we're only about 30 years behind the times. What we are increasingly seeing, though, is electronic health record systems being used to record the care given to patients. And I believe this gives us the opportunity to not just record the care patients receive, but also create systems which enable learning from the everyday decisions that doctors and nurses make. So we're going to trial a system which allows us to capture and learn from treatment decisions, and in doing so, generate reliable evidence as to the effectiveness of these treatments to guide doctors when they encounter the same situation for future patients. The system we've created will use computer alerts delivered automatically to the doctor or nurse at the time they make a particular treatment decision. When we have good evidence for a treatment, the alert is going to tell the doctor about it. But when we don't have good evidence for a treatment, the alert will ask the doctor to follow a randomly allocated treatment decision in just the same way as a standard clinical trial. Importantly, because this is integrated within existing computer systems, it's much less costly than running a normal clinical trial. Final point. This is a new way of thinking about how we learn from everyday decision making. Computers are helpful and necessary, but it's humans that make the decisions and patients that receive the consequences of those decisions. So both patients and clinicians are going to be central to making this work possible. So I'm going to take this opportunity to thank the patient and public representatives that have been involved in helping develop this work so far, and ask that if you're interested in some of the things I've talked about today, it would be fantastic to hear from you. So please do get in touch in the comments. Thank you for listening.
Amazing. Thank you so much, Matt. I'm especially taken by the idea that Matt's system, if you don't know exactly what the right thing to do is, it will give you something random to do. And I just wish the same were true to people who book comedy panel shows for the BBC, because here I am, ready to go at any time. None of them know what they're doing. They should just book me at random. That was lovely, Matt. Thank you so much. Let me go and have a look who our second speaker is. Oh, I'm very excited. I'm very excited about all of our speakers. You might find that in front of some speakers, I say, oh, I'm very excited about this one. I'm very excited about all of them. I have no favorites within this entire system, apart from Georgie, who you met already, who is my favorite. Let's go and talk to our second incredible speaker. So wherever you are, could you please applaud like crazy and welcome their face onto your screen? It's the marvelous Neel Desai. Hello, Neel.
Hi, Steve. Thank you so much for your introduction. Hi, everyone. As Steve said, I'm Neel. I'm a pharmacist and a PhD researcher based at UCL School of Pharmacy. And I want to take you back to the very first time you ever took a medicine. Now, for some of you, that memory might be a little bit hazy, but it's important. It's the first time you ever interacted with a medicine, and that can leave a lasting impression. For me, I was a young boy, no older than the age of 5, and was learning how to ride a bike. Now, we all know learning how to ride a bike has several crashes involved. And on this one particular sunny summer's day, very much unlike today, I ended up landing knee first onto the tarmac. The accident itself caused a very nasty cut, the scar of which I still carry today, as a reminder to my future self to always teach children to wear knee and elbow pads when they learn to ride a bike for the very first time. I remember the blood that came out of that cut, and boy, do I remember the pain that it caused. That stinging sensation you felt when you see an open wound for the very first time. I mean, seriously, God, that hurt. But honestly, that pain at the very center is really what took me back. My parents, like so many of yours, had a medicines cupboard, and they still do today. My mum rushed inside, grabbed a bottle of Calpol, as well as grabbing some plasters. She cleaned up my wound and she gave me a dose. That dose of Calpol didn't stop my bleeding, and neither did it stop the scar that I had from forming. But boy, it helped with my pain. You see, this stuff right here, Calpol, it blew my mind. As so many of you will know, Calpol contains paracetamol. It's a common painkiller used all over the world that can help reduce pain and reduce fevers too. As I grew older, the bottles of Calpol were removed and disappeared entirely from my parents' medicines cupboard. And in fact, they were replaced by these boring white foil strips containing white tablets. So these white tablets make it far easier for me to carry my paracetamol around than a bottle of Calpol. And you can find these paracetamol products everywhere you go, from Poundland to your supermarket and even in your pharmacy. So you see, we have a choice. In fact, if you go into your pharmacy, you'll find a whole range of paracetamol products. Actually, all of those, a box full. So prescription medicines, on the other hand, you don't actually have the same choice with. Yes, some medicines are available as different generic brands, as well as the main brand themselves. And that allows you for some choice. But often, pharmacists like myself, we supply patients with whatever we have available, because that's what we have. Now, here's an example. You could take Becanase, which is a nasal steroid spray that you can use for hay fever, something that a lot of people suffer with at this time of year. It's available as the brand, as I said, Becanase, but it's also available as a generic. So if a patient doesn't get on well with that particular brand, Becanase, and prefers an alternative, the generic, we can request for it to be written on the prescription for continuity and to supply the preferred brand to that particular patient. Of course, with these name brand situations, we end up in one of two choices, particularly if the medicine becomes unavailable. The first is the patient tries another pharmacy in the hope that it's available. Or the second is the patient just has to wait until they return back into stock. Of course, there is an issue if the patient can't take the medicine for whatever reason. In this case, a spray might not be compatible with the person's nose. They might find it itchy, stinging, or cause a range of other symptoms that they might not be particularly suited to. And that makes the medicine inaccessible. And what that can lead to is an interruption of treatment, and that could lead to negative results in the patient. So what choice do you really have? Well, that choice, the ability and willingness of an individual to take their medicines as intended, is known as medicine's acceptability, and it's the primary focus of my research. When patients have no choice but to take the medicines that they've been prescribed, the product needs to be designed in a way that allows a patient to continue to take the medicine for the whole length of the treatment course. For some people, that could be a short course, just a few days, but most likely it's going to be lifelong. It's not an exact science, and it requires a lot of trial and error to ensure that the final medicine is suitable for as many people as possible. But medicine's acceptability is becoming increasingly important, particularly for products designed for children and older adults. Going back to Calpol, right? It's designed for both children and adults in mind. For kids, it tastes delicious, well, according to the sugar versions that I've asked kids about. And for adults, it's easy to dose, based on the syringe that's available inside. My work looks at taking this testing and making it more relevant through taking lots of data from lots of different experiments that are more relevant to what's going on inside your mouth. And that means I end up with a lot of data to make the process of designing more acceptable medicines for pharmaceutical companies a little bit easier. So I've explained why and shown you glimpses of how my research will help shape the way medicines are designed and delivered in kids in the future. Thank you, and stay tuned for updates.
Amazing. Amazing. Neel, do you all those paracetamol products, do you have to take them back to the pharmacy now? Did you just borrow them?
I did, yeah. It's a short-term loan.
You didn't dent any of the boxes pouring them out, did you?
I might have.
Oh dear. Okay, good. Well, anyone who gets a dented box of a paracetamol product, you know why. It was all in service of letting you know more about those sorts of things. I'm a parent of young children. If any of the rest of you are parents of young children, you know that Calpol is essentially magic juice. It's the greatest thing. It's the last thing you do with parenting. Like after Calpol is we ring a grandparent for advice or we go to hospital. Those are the only two things after Calpol. But Calpol's meant that we've never got that far. It's been absolutely wonderful. Now, I'm going to fly to our next speaker. Now, our next speaker, I double checked, has the same surname as the first speaker, but they're not related. In case you were thinking that this is a very insular group of people that we've got. It just happens to be that Wilson's quite a common name. So we've ended up with two of them. So wherever you are, can you get your hands, hold them out like this, bring them together. But don't just do it once, because that's weird. You've got to pull them apart and do it together over and over again. And welcome into your screens and into your lives, the wonderful Emma Wilson. Hello, Emma.
Hi, thank you very much. So my name's Emma, and I'm going to talk to you today about my research in digital and newborn health. But before I do that, I'm going to tell you a little bit about me. So I've been really fortunate to have grown up in lots of different places. My dad was a general surgeon, which meant that basically he was happy to hack into any part of the human body. And he worked mostly overseas. So I got to go to places like the Caribbean, the Seychelles, and South Africa. And all this moving about gave me a curiosity about people and about different cultures. But more importantly, it made me realize very early on that simply because I was born in the UK, I was privileged and lucky, and that most other children my age in other parts of the world didn't have the same chances and opportunities that I had. And I found it really annoying when adults would tell me, well, Emma, that's just the way it is. I didn't buy that, and I still don't. And I always knew that I wanted to do something to try and address this balance. And being a researcher, and particularly a researcher in global health, allows me in some small way to do this. Before I go on, I'd like to introduce you to my cousin, Susie. So this is Susie and me, aged about 9, with my great-grandmother. Susie's the one in blue, and I'm the one with the dodgy red necktie. We're both obviously all grown up now, and Susie's become a neonatologist, which is just a fancy word for baby doctor. She looks after newborn babies who are sick or who are really vulnerable as they were born too early. And most babies in Susie's care survive. They get treated in a ward with all the latest state-of-the-art fancy equipment. And someone like Susie, who studied babies, and only babies, for many years, is there to help around the clock. In sub-Saharan Africa, in countries like Malawi or Zimbabwe, where I do my research, many babies who are sick or born early don't survive, and they don't get to go home. In fact, many will die. A baby born in Malawi is 7 times more likely to die in the first month of life than a baby born anywhere in the UK. And the tragedy is that most of these deaths are entirely preventable. In fact, 70% of the 2 million newborn deaths globally each year could be prevented. So if these deaths are preventable, why aren't we doing just that, preventing them? We know that it's the simple things that matter. Babies who are not breathing at birth need to be resuscitated, and quickly. Babies who are cold need to be kept warm to prevent hypothermia. And doctors and nurses need tools to diagnose infections such as sepsis, so that the right babies get the right treatment at the right time. But even these basic, simple things can be really hard to achieve in places with limited resources. When a nurse only has a few weeks of specialist training under their belt, how can they resuscitate a tiny baby with confidence when the pressure is on? How do doctors accurately diagnose infections such as sepsis when they don't have access to a working laboratory? And how can health managers know where the problems lie and where improvements are needed without reliable data to tell them? Well, what I believe, and the amazing team I work with believes, is that the solution, or at least part of the solution, could be a digital one. This is the Neotree system. A central piece of the Neotree system is a digital app. It can be downloaded onto any affordable Android tablet, like this. And once the app is downloaded, nurses and doctors can then use the app to record all the important data about every sick baby in their hospital. Having the data in a digital format is crucial. It increases the chances that the data actually get used. The Neotree also helps nurses to manage babies in an emergency. It helps them to perform life-saving procedures such as resuscitation. And perhaps most cleverly of all, using the data that we have and that we're collecting, we are building algorithms to support nurses and doctors to diagnose common conditions such as sepsis in places where lab facilities are scarce. So this is all well and good, but does the Neotree work? Well, what we do know is that it can be used in settings like Malawi and Zimbabwe. It's been used to provide care to over 13,000 babies to date, and it fits in with nurses and doctors' ways of working. This is such an important first step, as so many technologies can end up in the bin if they weren't developed for and with the end user. But does it save lives? Well, this is something we're still figuring out. Hopefully the next time we meet, I'll have the answer to that. Thanks very much for listening.
Wonderful. Wonderful. Thank you so much, Emma. We'll see you in a few minutes for our panel discussion, won't we?
Yes.
If anyone's got questions for Emma, do put them into the YouTube chat now, and we'll make them part of that wider discussion. Let's keep flying around the UK and visiting different parts of different experts' houses, shall we? And the next place we're going to go is Sarah Abad's house. So I'm just going to double check that Sarah's there. Yes, Sarah's there in a very interesting looking room. Very excited to reveal this one to you. Wherever you are, would you mind applauding, please? And welcoming into your home, Sarah Abad.
Thank you, Steve. Well, my name is Sarah Abad, and I work as a research fellow at the Mechanical Engineering Department. Today, I'm going to talk about the touch sense and how we don't realize how much important it is. First of all, I would like you to picture sleeping. Midnight, light switch, panic time, because you need to go to the toilet, but it's too dark, so you search for the lamp switch. You use your hands, your touch sense in the search of the switch. I'm pretty sure that you're familiar with this game, Operation. This may look a bit different. It is because it is a more accurate version, because I am a scientist after all. If you are not a surgeon, this gave a minimum idea about how demanding surgery is. Doctors who perform minimal invasive surgeries using robots can be in worse situations. During these surgeries, the doctor is not in a direct contact with the patient. A camera usually provides visual information of the working area, but there are cases where camera cannot provide an image, and doctors cannot use the touch sense to understand what are they manipulated. In the light switch case, the worst case scenario is that you will need a change of trousers, similar when I spill my drink in my trousers. But for surgery, it implies that the patient may need additional surgeries or treatment because all the cancerous tissue was not removed because of the lack of touch sense. There are several interfaces to display touch sense information, but doctors prefer not to use them because they are mentally demanding and require intensive training. For instance, there are interfaces that display the information in screens, apply vibrations to your fingers, or another stimulus to provide that touch sense information. However, this is distracting for doctors because they have to consciously do an internal mapping between the perceived signal to the corresponding touch information. This means that the brain of the doctor has to do an extra effort to understand the stimulus. Surgery itself is already demanding for doctors. That's why, therefore, doctors prefer not to use current touch interfaces. To break these limitations, I am developing a fingertip interface that uses a more transparent, intuitive approach to provide touch information. This means that doctor and anybody will need a minimum training in order to understand the received stimulus. The fingertip interface aims to simulate the stimulus received by doctors when their fingers interact with real objects. This implies that the brain doesn't require that extra processing. Another advantage of this fingertip interface is that it can be applied in other tasks. Different factors such as current pandemic, the search for better job opportunities, or due to other personal reasons, families don't live together. Therefore, video calls are the most vivid way of interaction. How many calls do you have per day? I count them. Once I had 6 meetings in a day. I don't know about you, but I miss the face-to-face meetings. Meetings with friends where we used to interact a lot, for instance, playing games. Meetings with your mom or your kids where with a caress is important to show them how much you love them, how much you miss them. However, current technologies only allows you to see them in a screen. But when you're hyperactive, as I am, it's hard to see people for more than 10 minutes in a screen. Of course, this doesn't happen so often, but at the end of some calls, especially with my family, I also end up finishing doing other not so demanding stuff, such as playing Candy Crush or cleaning something. But after 30 minutes of the video call, I sometimes realized that my brother was talking about something really interesting. Then I had to ask him to repeat again what he said, which makes our video call even longer. Well, with this interface, video calls can become more interactive. Maybe I can prank to my nephews at some point. I'm looking forward to it, actually. Thank you so much.
That was wonderful, Sarah. That was wonderful, Sarah. And just on behalf of everybody, I'd like to acknowledge how jealous we are of the incredible tool management and organization that's going on in your house. I have to keep all my tools in one drawer. I can never find anything. Your talk was also brilliant, but I was just overwhelmed by the control that you have over your space. Let's move on to our next wonderful speaker. He says, looking at the list, oh yes, another great one. I mean, they're all great ones. So it's kind of, I mean, you might think it's redundant that I say that, but that's not really how language works, is it? Language is about many more things than just the passing over information in the smallest number of words. So when I say another wonderful one, I'd like to think I'm doing more than just reminding you of what you already know. But I'm very excited that they're going to be here. So would you all please, wherever you are, clap. And if you want to, you can cheer as well, because I think our speakers are worthy of that. And welcome to your screens, Helen Matthews. Hello, Helen.
Hi, Steve. Thank you very much for the introduction. Hi, everyone. I'm Helen, and I'm going to talk to you about cancer. So I'm a cell biologist, and I'm a cancer researcher. This means that I get to spend most of my working life thinking about cancer, reading and writing about cancer, doing experiments with cancer cells, and watching cancer cells divide down a microscope. You could say that this means I know an awful lot about cancer, and I do. But a few years ago, something happened that made me realize that, in fact, I know absolutely nothing about cancer. And this was when I was diagnosed with cancer myself. So we all know the stats. 50% of people in the UK will be diagnosed with cancer during their lifetime. And I'm sure every single one of you knows somebody who's been affected by cancer, someone who's had it or somebody who's died from it. Yet somehow, such is the cognitive dissonance of the human mind that you never expect yourself to be included in that 50%. And when I found a lump, I was absolutely certain that it wasn't cancer. You know, I thought I'd better get it checked out just because that's the right thing to do. But never in a million years did I think it would actually be cancer. And then it turns out that all the theoretical knowledge in the world isn't enough to prepare you for when a doctor utters those immortal words, "I'm afraid it's cancer." Luckily, I discovered that there's an amazing community out there of the real cancer experts, cancer patients who are experts in the brutal, messy, emotional reality that is cancer. And they picked me up, and together we traveled together on the emotional roller coaster that is breast cancer treatment. I had surgery to remove the tumor, and next it came to chemotherapy. Now, I might have been the first patient in the whole history of cancer treatment to have been just a teeny weeny bit excited about the prospect of chemotherapy. And the reason was this. The first chemotherapy drug that I was given was a drug called Taxol. And this is actually a drug that I use all the time in my experiments in the lab. Now, in the lab, Taxol is kept in a special locked cabinet known as the poisons cupboard. And it's kept in a tiny glass vial plastered with health and safety warnings like hazardous, human health, do not ingest, toxic, could cause death. So there was a kind of illicit thrill to the idea of getting Taxol injected directly into my veins. I wanted to know how it would make me feel. Now, there's actually a really interesting story behind the discovery of Taxol. Like so many medicines, it actually comes from nature. So in the 1960s, scientists in the USA realized that plants have this kind of awesome power to produce toxic chemicals. And they carried out a massive experiment where they took 15,000 different species of plant and ground them up and made extracts and sprinkled them onto cancer cells. And one of these extracts came from a tree, from the bark, in fact, of a tree called the Pacific yew tree. And they found that when they sprinkled it onto cancer cells, it was very effective at killing cancer cells. And they eventually isolated the compound that was so lethal to cancer cells and named it Taxol. And it went on to probably become one of the most successful chemotherapy drugs in the world. But because Taxol was discovered in this kind of random, let's just grind up plants and see what happens kind of way, it wasn't immediately clear why it killed cancer cells. And it took a lot more research to discover this. And what it turns out is that Taxol actually works by killing dividing cells. And this was why I was working on it in my experiments in the lab, because I study the process of cell division and how cancer cells divide. Now, the majority of cells in the human body don't actually divide. If you think of an organ in your body, such as the heart, the cells are really just sitting there, especially when you're an adult, just doing their thing, and they're never going to divide during your adult lifetime. And the same is true for many tissues. And even the cells in your body that do divide, they will only divide if they get a really specific biochemical signal telling them that now is time to divide. The default position of cells in the human body is not to divide. And cancer is what happens when cells go rogue. They ignore this message and they just continue to divide and divide and divide and grow without stopping. And Taxol works because it kills cells that are dividing. And because cancer cells divide way more than normal cells, then it kills cancer cells more than healthy cells. So how did Taxol make me feel? Well, unsurprisingly, the answer is pretty lousy. Before I started chemotherapy, one of my amazing cancer buddies described it as being like a cross between your worst ever hangover and the first trimester of pregnancy. And of course, it's different for everyone, but I have to say, I think I felt worse than I ever did when I was pregnant. But it probably wasn't quite as bad as my worst ever hangover, thanks tequila. But of course, the side effects last a lot longer than a hangover. And this is really the problem with chemotherapy drugs such as Taxol. The side effects can be really horrid. And this is because there are cells in your body that actually do need to divide. And Taxol doesn't distinguish between these healthy cells and cancer cells. It just kills dividing cells. So some of the cells in your body that need to divide include cells in your gut, your hair follicles, and immune cells in your bone marrow. And so it's no surprise really that chemo leaves you feeling sick, you lose your hair, and you become susceptible to infection. Yet despite the tiredness and the queasiness and the hair loss, I'm actually really grateful to Taxol and the scientists who discovered it. So 4 years on from my cancer treatment, I'm cancer-free and I'm back in the lab. And for the most part, my experience as a cancer patient has spurred me on in my research. I want to understand what it is about cancer cells that really keeps them dividing and why they keep dividing without stopping. And I hope that perhaps one day that might lead to better and kinder therapies that could be used to treat cancer patients. Because I think really understanding cancer cells has got to be a better strategy than just grinding up random bits of plants, right? Thank you.
That was wonderful. That was wonderful. I did a little bit of research while Helen was talking about why is Taxol called Taxol, because I wondered if it was some kind of political comment by the scientists who found it based on the fact that it kills things that are growing, but it's not. It's just to do with the name of the plant. The genus of the plant is Taxus. That's why it's called Taxol. Please don't write in with your political comments. We've got two more incredible speakers before I bring them all back together so that we can probe their combined intelligences. And I'll get the first of those speakers on now. You could say he's our penultimate speaker, because in an event like this, we're safe that knowing that all of the other speakers know what the word penultimate means, which is quite rare for some of the events that I do. So wherever you are, would you put your hands together for our penultimate speaker, Peter Widger-Atner.
Thanks, Steve. Hello, my name's Peter, and I'm a Medical Research Council Fellow based at the UCL Department of Computer Science. I've had a bit of a random walk through research, from studying theoretical physics at undergrad to doing my PhD at the Large Hadron Collider at CERN, to then switching fields and using maths and physics in medical research. Now my research focuses on machine learning in medicine, which is a fancy way of saying I use maths, computers, and data to try to make medical predictions. I'm particularly interested in diseases of the brain, such as Huntington's disease, and trying to predict how someone's disease will progress. As you might have gathered, trying to predict the future plays a big part in my research. At the heart of any prediction is probability, or the mathematical formulation of chance. Anyone can say they can predict the future. But when presented with certain information, how do we arrive at a prediction? To answer this question, I'm going to talk about a famous, and some might say infamous, problem in probability, the Monty Hall problem. So what is the Monty Hall problem? Well, it's a brain teaser named after the host of a US TV game show that gained widespread attention after a reader of Marilyn Vos Savant's Ask Marilyn column in Parade magazine in 1990 posed the following question. Suppose you're on a game show and you're given the choice of 3 doors. Behind one door is a car, behind the others, goats. You pick a door, say door 1, and the host, who knows what's behind the doors, opens another door, say door 3, which has a goat. The host then says to you, do you want to pick door 2? Is it to your advantage to switch your choice? Audience interaction alert. What would you do? Stick or switch? And why? We can all agree that the chance of picking the car in the first place is 1 in 3. But what happens to our chances after the host opens door 3? Now, I'm going to be honest here and say the first time I heard this problem, posed to me by a flatmate back in my Manchester undergrad days, my brain was shouting for me to say, it doesn't matter. Because if there are now only 2 doors, then the new odds are 50-50. But being a physics student and generally distrustful of my flatmate's questions, thanks very much, Gethin, I also had another voice saying, steady on, something's not quite right here. So how do we tackle the Monty Hall problem? Well, when approaching a maths problem, the first thing I do is to define what assumptions I'm making. In this problem, I'm going to assume that we want to win the car. Some people might want to win a goat, fair enough, each to their own, but we want to win the car. So when the host asks us, do you want to pick door 2? They're really asking, do you think your chances of winning the car are better if you pick door 2? We're also going to assume that the host will always reveal a goat and never the car, because that would spoil the whole game, and where's the fun in that? Now, the key insight into solving the Monty Hall problem is realizing that the host knows what's behind the doors. Therefore, the decision they make as to which door to open isn't completely random. It depends on the choice that you have made. Say you actually pick the car in the first place. That means the host now has a choice of opening either of the other 2 doors, because they both have goats behind them. But if you initially picked a goat, then the host can only open one of the other 2 doors, because the remaining door will have the car behind it. In mathematical terms, we call this conditional probability. That is, the chance that an event happens is dependent on another event. So if we write down these possible outcomes, what do we get? Well, apart from a piece of paper covered with the word goat, we can see that if we stick with door 1, there is a 1 in 3 chance of winning the car, but if we switch, there is a 2 in 3 chance. So our chances of winning the car double if we switch. This seemingly counterintuitive result has bamboozled boffins for decades. And while Vos Savant correctly answered the question in her column, nearly 1,000 PhDs wrote in to tell her that she'd got it wrong. So don't feel bad if you decided to stick. Probability is weird. Now, why does this all matter? Well, what if we're not a contestant on a game show trying to win a car, but a doctor in a clinic trying to pick the right treatment for a patient? We want to use the information we have about the patient under certain assumptions to say things like, given that patient X is 80 years old, I think they should be prescribed treatment Y. And this is where machine learning comes in. It can help us to learn the probabilities from many, many possible sources of information and help guide us to make the best decision for the patient. This is one of the big ideas behind machine learning in medicine, using machines and maths to help doctors pick the right treatment at the right time for a patient, based on the data that they have available. So next time you're on a game show and the host asks if you want to stick or switch, you'll know what to do. Unless, of course, you just really like goats. Thanks for listening. Over to you, Steve.
Thank you so much, Peter. I mean, there are times when you get a mathematical result and you just think, maths itself must be wrong. But you did explain that one brilliantly. The one I'm thinking of, maths people, is it the sum of all whole numbers, which turns out to be some weird fraction. Peter, do you know this one? Do you know it adds up to something like 5/8 or something, or -5/8, and you just think that can't be right. Maths itself must be the thing that is wrong. Thanks so much, Peter. Monty Hall problem. I think one of the debates we had during the development of this is the Monty Hall problem why the 3-card thing is called 3-card Monty, or does that come from somewhere else? If any of you are historians of con games, do let us know whether that comes from the Monty Hall problem. But before we dive to Wikipedia to try and work that out, and before I bring all of our wonderful speakers back so that we can pick their brains, I've got one more speaker for you. So wherever you are, would you please put your hands together and applaud for Reza Motalabzada?
Hi, thank you very much, Steve. Thank you. My name is Reza, and I'm a kidney transplant surgeon, and also run a research lab in UCL looking at how we can improve the lifespan and function of kidney transplants. Many of you have hopefully been enjoying the recent hot weather, but I'd wager that no one, or at least very few of you, have been thinking about what our kidneys have been doing to cope. Because while some of you might have been keeping up adequately hydrated by taking on more fluid, there will be others, and myself included, that probably haven't been. Yet our kidneys are quietly working in the background, and either making more urine to get rid of excess fluid, or indeed doing the reverse, and cutting back a little the amount of urine they make and conserving fluid, yet getting rid of all the toxic waste products that our cells make. But for people with long-term kidney disease, which affects over 7 million people worldwide, this fine balance that the kidney performs gets irreversibly damaged, and the ability to get rid of this excess fluid and harmful toxins is lost, as well as other important functions that the kidney performs, such as controlling blood pressure, calcium levels, and the amount of red blood cells that we make. And so the kidney really is a remarkable organ. But if a person develops kidney failure, then buildup of these toxins can be fatal within a few days. So patients with kidney failure have to be supported in one of two ways. Either for the excess fluid and toxins to be removed from the body by a process known as dialysis. And in the UK, about 2/3 of patients with kidney failure, that's around about 20,000 patients a year in the UK, receive regular dialysis through a machine, where all the blood is taken from someone, washed to get rid of these toxic waste products that our cells make, and then cleaned and returned back to the patient. And this is what happened to a close family friend of mine who developed kidney failure due to his diabetes. He had to have this 3 times a week for 3 to 4 hours at a time, and he'd feel pretty tired and lethargic, sometimes with some muscle cramps after each session of dialysis, not least of which having dialysis interrupted his work and his social life. But better than dialysis to support failing kidneys is to get a new kidney, a replacement kidney in the form of a kidney transplant. And kidney transplantation really is a modern medical miracle that can transform the lives of patients with kidney disease. And in the UK, we perform about 4,000 kidney transplants a year. And 2 years ago, my friend was incredibly lucky enough to get a kidney from his sister in an act of tremendous generosity. However, there's an Achilles heel to transplantation, and that is rejection. And rejection happens because of our immune system. And whilst our immune system is really good at detecting and getting rid of things that don't come from our own individual cells, such as bacteria and viruses, it also sees a transplanted organ as something that doesn't belong to us because it came from someone else. And it also tries to get rid of a transplanted kidney. All in all, 1 in 3 transplants can suffer from rejection. And whilst in most cases we have drugs to counter this, there can be scarring of the kidneys as a result of rejection. And this can ultimately lead to the transplant failing, with options of returning either to dialysis or getting a new transplant. It's not always easy. We diagnose rejection by taking a small sample of the kidney transplant using a long needle that goes through the skin and into the kidney, taking that sample out, putting it under a microscope, and looking for collections of immune cells that are attacking the kidney. And yes, my friend also had to have a biopsy of his kidney transplant 6 months after his surgery. As well as the procedure being painful, it obviously caused a lot of anxiety, as he was worried about whether he had rejection and if the lifespan of his transplant was going to be affected. But work from my group and other researchers are looking at better and earlier ways of diagnosing rejection. And one way is to look at the urine, what I would call a window into the soul of the kidney. When immune cells attack a kidney during the rejection process, they release these signaling cues, certain proteins, to recruit more immune cells. But this leaves behind a fingerprint in the urine, and we have shown that we can detect these signaling proteins in patients who develop rejection. However, the process of this detection takes a few hours and uses up really specialist equipment. I thought, how can we do this better and quicker? Could we do this by the patient's bedside or in the clinic? So I teamed up with some really clever mechanical engineers at UCL, and with some generous funding from grants from the Rose Trees Trust and from the UCL Institute of Healthcare Engineering, we are developing a special device to speed up the chemical reactions that are needed to detect the signaling proteins that immune cells make in the urine, and to do this on a cartridge no more bigger than an iPhone, and with the result coming back in under an hour. So hopefully we can detect and treat rejection a lot earlier than currently possible, and reduce the amount of anxiety that transplant patients have when we monitor them in our clinics, and go to some way to improve the long-term function of kidney transplants. I'm really happy that you're able to join me today and listen to my talk. Thank you.
Great work, Reza. Great work. I've just pulled out the quote, urine is a window into the soul of the kidney, is one of my favorite things that anybody's said today. Let's bring all of our panelists back on screen so that we can start to ask them questions. And remember, you can ask us questions in the YouTube chat, and I will put them to our panel. But I'm going to start by asking all of the panel this. And when I say all of the panel, I'm going to come to Helen first. So Helen, start thinking. And the question I've got for you is, Georgie's already advertised this scheme again for next year, but we'll have people watching this who are researchers who aren't based at UCL. Maybe they're not eligible for something like this. Maybe they just don't get on. So I would want to ask all of you, what's the thing each of you has learned, or the big realization that you've had that you'd like other researchers who do similar things to you all over the world to know? You know, if we had to do I think on the internet they call it a TLDR, a too long semicolon don't read, for people like you who are thinking about impact, but they've not had this sort of course. Is there one thing that each of you's found out or realized or learned that you'd like every researcher like you to know? And Helen, are you all right to answer this one first?
Yeah, I can give it a go, no problem.
And then what I'm going to do after Helen is, for the rest of you, just dive in after Helen whenever you've got something to say. And when it all dries up, I'll give you another question. Thank you, Helen. Do lead us off.
I guess for me, in terms of communicating research, my top tip would be you just can't you can't make it too simple. I mean, as scientists, we're really used to trying to express really complex ideas and going into a lot of details and caveats about everything. And actually, really, you just need to talk to people in a way that you would just talk to your mates in the pub, and try and kind of keep it simple and not worry about glossing over details, which is really hard to do as a scientist, because, the details are very important in science, but you have to kind of ignore that. So I think from a science communications point of view, that would be my take-home message.
Fantastic, thank you. And who else would like to dive in with the one thing that they want everyone in their industry to know from this year?
Well, I will share my experience. I am not native speakers. Okay, you have noticed my strong accent. And for me, since I have been studying all my life in UK, so for me, I don't have an idea what common words are. So when somebody was asking me, okay, do a pitch about 5 minutes, and of course I was using my everyday words, which were not everyday words for everybody. So I remember we had a workshop actually when one of the speakers provided us with a link to the 10,000 lay works. That was the best thing for me, because it's like, okay, I will Google it. Is it in the list? It is not? Okay. Well, I am a roboticist, and unfortunately robots were not there, so I had to go around to cope with that.
Fantastic. because I learned from all of you all along as we've been through, even just putting the talks together for today. Sarah, for instance, I quoted what you said about the problem with uptake of some of the technologies that you work with amongst doctors being that they've got a long learning curve and doctors don't want to learn them, so they just refuse to do it. I quoted that to a doctor who said, no, it can't be that. The technology must be no good. Sorry, I was just quoting what an actual researcher told me. So for everybody else, what is the one thing that you wish every researcher like you knew if they went through a year like this? I can pick on people if that makes it easier. Reza.
I think some of what's been said already, I'd like to really reiterate. I think, but also add that speaking to patients and understanding exactly what's important for them. I know it sounds obvious, but we don't do that enough. And I think that engagement process is really critical to make sure that what we're doing is actually worthwhile. Because if it's not important for the patient and we're just making assumptions, then we're not using up our time or resources effectively. And that's really come out by this year's process. And I agree also with we can't get rid of enough of medical jargon as possible. I mean, there's no limit to that, and distilling that down into understandable language is a tough ask. I found that hard, I have to admit. But being on this course for this year has really helped to shape and focus my thinking on that.
And just to fly over to Matt for a second. Matt, as an expert in talking to patients, or at least I assume you are, because every anaesthetist I've ever met has been an expert in talking to patients. Like the only person in the room whose job it is to talk to the patient, and often just because of my professional and personal life, I've been in operating theatres on a few occasions, and it's always the anaesthetists who are best at chatting to us. Matt, what have you picked up this year that you wish that everybody knew?
Yeah, I think there's a spectrum across all different specialties, and there are some anaesthetists who don't do that very well, and there are some that do excellent jobs. I think probably what I've learned from that perspective is that the distilling of complex ideas into discussions with patients and the public is not just a one-time event. You get better at it the more you do, and you get more out of it the more you do. Because I think there's quite a temptation now, because there's a mandated PPI involvement when you're writing grants or when you're doing any kind of research on patients, that you do the minimum necessary. But actually what I've gained and continuing to gain is ongoing patient involvement in the project, and things change, and it changes your work, and it makes it more relevant and more specific. So I think, and it makes you better at it, I think, as well, and better at communicating. So it's not just a one-off thing, I think.
Fantastic. Thank you so much, Matt. Emma, what have you taken away or from this year that you wish that everybody knew? I notice everybody's being very cagey about technological stuff and commercialization stuff and entrepreneurial stuff. Are you all worried that somebody's going to jump in on your ideas? No. Anyway, Emma, tell me.
I think basically, yeah, what I've learned is that everyone can learn to be a better communicator. I think I always thought that sort of engagement and communication was for others, and that wasn't something that I could ever get better at. And I think what this year has taught me is that you can, and we've had some amazing training. So I definitely feel more confident. And I've also learned as well is to sort of keep it authentic. I think if you're talking about things that matter to you, inevitably you're going to be able to sort of connect with people. So yeah, I would thoroughly recommend it.
Fantastic, thanks. And how about you, Peter? I mean, you're in a subject where traditionally it's difficult to get applied mathematicians to talk to theoretical mathematicians, let alone get anybody to talk to anybody else. So what have you taken away from this year that you wish that all of your mathematician colleagues knew? And also, can you mute YouTube? Because it's running slightly behind.
Yeah, I've just been thinking while we've all been talking, and I think one of the main things that I've got from this past year is just thinking about how to communicate and talk and get across my research to different people. But I think this is also important and you're talking within your own discipline, saying, you know, we're not even making this separation between sort of public engagement and who I consider to be the experts, because I've sat in so many talks and delivered talks where, you know, I could tell the engagement just wasn't there at conferences and so on. And I think the same sort of skills apply when you're talking about your research academically. And, you know, I just think the sooner that you can start practicing and talking to all different types of people, the sort of better you can get your ideas across.
And are we going to get you all doing real events in front of actual audiences quite soon after this? Because I only worry because you can be the best presenter in the world, but at an academic conference, people still listen like this. They're emailing away. And they only move when you say something they don't like, when they go. It doesn't matter how good a presenter you are, but getting out in front of other audiences will help you build up those skills. Let's fly over to Neel and find out what Neel's takeaway was.
I think one of the biggest things was, so for me, science is fun, but science is frustrating. And I'm sure that's the case for everybody. But making science fun while it's frustrating is very difficult to communicate. And I think, obviously, one of the biggest things is listening and learning as part of that process as well. So I think we've practiced these talks numerous times. We've had feedback from others, whether it be the cohort themselves here or friends, family, whatever it is. So, you know, whilst we do the science and we go out there, we really want to show off. Sometimes it's important to take a step back and actually listen and say, or even listen to yourself or listen to others and say, my work is not going in the right direction. My work does not make sense. Maybe I should take a step back and replan or reroute, get more data, whatever it is. So I think, yeah, it's helped to put into perspective more what my research means to me. And if I can explain it, as Helen kindly said, to my mates at the pub or to my family, and they're able to understand it, then I think I've done a pretty good job of communicating that across.
Wonderful. I mean, some of you out there will meet your mates in places other than the pub for all sorts of reasons, and that's just as good a place to explain your research to them. Just putting that note in on behalf of the equalities and diversity part of UCL. We got a question from Marilyn. So that question was about kind of abstracting wide learning from the whole thing. But Marilyn wants to know about specific things that have happened to you. So I'm going to throw this one on. I'm going to go to Matt first for this one. And do feel free to chip in. If somebody mentions a thing that you enjoyed, chip in and talk to them about it, share along the way. We're not a very formal panel while everybody waits to be invited to speak. I'm only telling Matt I'm going to him so that he knows it's on him to start the whole thing. So the question is, if you can only choose one out of all the things you've done, what's been the most enjoyable and impactful experience? I think what Marilyn means is the best bit. What was the best bit? And don't give me a general, it's nice to know when. I want to know that experience.
I'm going to massively pop out. It's definitely been doing this. Purely because it's been terrifying, but I'm glad I did it. And having kind of going through the process of doing this kind of talk, using different kinds of technology that I wouldn't be normally used to, speaking to different kinds of people that I wouldn't normally used to, both in a professional and a public capacity. It's been really eye-opening in terms of how my own skill level and my own ability to communicate things. It's brought home some of the earlier PPI, patient and public involvement work I did, which was pretty blunt in some of the responses we got. We came to the group with a really excited idea and basically we got told, we don't understand a word you're saying, it's utter nonsense. And that was a proper kind of, oh, wow. If I can't explain this now, how are we ever going to move forward with this project? So coming on and doing this has been a really enjoyable and rewarding process.
That was a good answer, but no one else is allowed to say this because our audience already know about this. They're watching
I was going to say that.
Oh, go on then, Helen. We'll let Helen do it. But, you know, we're trying to dig in and find out all the other things that you've been doing as Impact Fellows because you've had you've had a COVID restricted year, admittedly. But go on then, Helen. Tell me why you like this. Just Helen.
Well, I
mind.
think it's
the
just
rest
a
of you think of something else.
It's just a challenge to, and as Matt said, it sounded terrifying, and actually, it's a good. A lot of the training was really interesting, actually, and fun, but it wasn't. This has been a real challenge and something completely different, and I think that's what's been good. Actually, that's why. But yeah, it's been fantastic.
I'm just thinking. I'm thinking of the kind of public events and online things I put scientists through. This isn't terrifying. We'll get you doing improvised science communication, where you have to make up solutions to global warming using only a sponge and a bit of cheese and things like that. I do that as a live game show. That's way harder than this. Good. What else did? For other people? What was your best bit of your Impact Fellowship?
I'm going to jump in here before someone else takes it. I really enjoyed the guest speakers that Georgie and Alice helped to organise. So we had some sessions where we had people that were invited to come and talk about their kind of experiences in quite a sort of open way as to how they've gone through their sort of academic career and into science communication and sort of life stories and anecdotes and all that kind of thing. And a particular highlight was hearing from Dr. Kevin Fong, who has done some amazing things and has had a really sort of cool career and unusual path. And yeah, just sort of getting to hear firsthand from him and talk to these people has been a real privilege. So that's been a big one for me.
And what about for those of you we haven't heard from?
I'm going to jump in just in case anybody else pinches mine too. I think we've been quite fortunate to hear from different departments from UCL. And for me personally, we were able to get a talk from UCL Trellis Community Partnerships. So they're sort of an organisation that work with East London charities and community groups that enable researchers to explain their work to the general public. And from that, I've been able to get in touch with them and actually arrange over the coming summer to do very much the same thing over an extended period of time with a group of local children from East London. Mm-hmm. So being able to get into networks that we wouldn't otherwise have access to or would be more difficult to be introduced to in the first place has been really, really important for my research, but also really beneficial in terms of parts of the training that we've been able to get.
Wonderful.
I think also the relationships that are built up among us as a cohort, I think we started off being a bit shy, and I think it's been really lovely, particularly for this event, how we've kind of pulled together and supported each other. And it's been a great opportunity that way. And that's kind of as well sort of the informal meetings that we have sort of once a month where we kind of check in on each other, and that's all coordinated by Georgie. And that's been, I've really sort of benefited from that, definitely.
Go on, Reza. I saw that microphone unmute.
Yeah. I was going to say that actually listening to everyone's talks and learning about what everyone is doing in their research programs and profiles has really been fascinating. And actually, I think just communicating that across UCL has been, for me, a real eye-opener in what we're all doing. So I feel quite privileged that I'm in an institution that does such amazing work.
Well, personally, in my case, I think my confidence improved. Confidence to talk to people, unknown people like, policymakers, or like in my case, it was the beginning for a second fellowship. Now I'm having a policy impact, so I will actually submit something to be discussed, a post note. So it's actually quite nice because it's the beginning to something else, and that for me is really good.
Fantastic. We have a question that's come in through our private chat, which is, so what's next then? You've built up all these skills, you've had all these ideas for impact. What's the thing you're going to do that goes out and has this massive impact outside of academia based on all of these new skills and links and ideas and that sort of stuff? I'm not going to pick on somebody first. Part of this is you're all learning leadership, so one of you is going to jump forward.
I was going to say I'll jump. Probably do this kind of thing more often, whether it be a formal setting like this, or maybe more informal. I know I've had the privilege of recording a couple of podcasts as well through UCL, which has been really enjoyable. So it's very different.
Neil, can you tell us which
activities.
podcasts they were, so that
Yes,
any nascent Neel fans can go and find them?
Yeah, sure, perfect. So one of them is part of the Innovation Knowledge Exchange Network that I'm a co-lead of, which is called Celebrate. It's run by my supervisor, and I'm, as I said, a co-lead of that. And we've started a series of podcasts that explore research happening at different levels within the pharmaceutical industry and the design and development of medicines for older people. So the first podcast was with a researcher based at Aston University in Birmingham, and we're going to have some talks from industry, from charity groups, from academics, just to see their insights and their inputs. And the second one,
is it on iTunes and all of those places where people can find podcasts normally?
It's currently only on the UCL website, but we might host it there in the future.
I can get it out to where the podcast listeners are. Cool. And what was the other one?
The second one is part of UCL Grand Challenges. They have a series of podcasts that have been running since at least the start of COVID-19, which gets researcher insights from all across UCL about different issues. So my one in particular was looking at the older population and how we can use prescribing in terms of medical prescribing and being a pharmacist and providing services, but also social prescribing to help make older adults more independent.
So your impact is at this kind of the point where prescription practices meets the understanding that patients and publics have, and changing that sort of whole area. That sounds brilliant.
Exactly.
And what about everybody else? Oh, sorry.
No, sorry. I was just going to say it just takes my work from what I do in the lab and what I do in a pharmacy and sort of combines the two into giving a finalized product that should help improve older people's lives.
Fantastic. And what about for everybody else? What is the impact? It's a tough question, I know. But you're going to write grant applications. You've got to get used to answering this question. Peter.
So one of the things that I'm going to be doing this summer is in collaboration with this great organization called InterScience UK. And what they do is that they provide what's essentially a summer school for A-level students to try and provide support for their UCAS applications to university. And I'm working with them to deliver a course on computer science, which is, quite a sort of jump, I think, from high school level subjects. I had no idea what computer science was when I was many years ago at school. So I'm really excited about that, and I think a lot of the skills that I've learned on this fellowship program will really help with that, particularly the communication and thinking about the sort of context of who I'm speaking to and how to speak. So I'm really looking forward to that.
Once we've got you skilled up for talking to A-level students, the next challenge is 14-year-olds, because the challenge with 14-year-olds is that they're only interested in what is cool, and that nothing is cool. It's a very difficult group to talk to. So for everybody else, what's your projected impact? Where do you think all of this is going?
Well, in my case, I have been already using it because I have been working in a lot of projects at the same time, especially with abroad partners with Ecuador, and I have to communicate with doctors, with engineers, and also with policymakers. Actually, something quite interesting was that at some point the Minister of Health came to visit UCL, and I was invited, so I have to give a presentation to that as well. So actually, it has been really helpful because since before this fellowship, I didn't have a clear idea of how to engage with these different people, but now I have a kind of baseline, so it's really good.
Is this the current health minister in the UK?
No, the Ecuadorian one, and the government changed, so he's not the same anymore. Right.
Okay. Good. Because lots of people have strong opinions about how you interact with the current Secretary of State for Health in the UK. And for the rest of you, what's your impact going to be?
We're going to have an ongoing kind of public and patient involvement project ongoing all the way through my PhD and hopefully afterwards as well. And one of the things we're specifically interested in is both kind of broadening who gets involved in putting input into research, but also making it specific at the same time, because there are loads of underrepresented groups in patient engagement in research. And one of those in particular is people who go through intensive care experiences and critical care survivors. So they're very hard to access because it's a horrible experience and no one wants to really go and talk about it again, let alone be involved in, you know, shaping other people's experiences through research. But it's a really, really important role. And so we're going to be talking with the intensive care kind of patient charities and representative groups about how we can get more people involved through that.
And if we have people watching who have been in intensive care and they would like to help, who are the charities and groups that they can get in touch with to say, I want to be part of your organisation working with people like Matt?
So the main one is ICU Steps, which is a national charity. And then if they want to get in touch with the University College London Hospital's patient and public involvement group, there are details on the UCLH websites that they can access. And then if you want to be part of what we're doing as well and have some impact into that, we'd love to hear from you. And you can get hold of us through that website as well.
Fantastic. Helen, you've had your mic unmuted as if you're ready to go.
I'm not sure about that. I think I'm still in the process of trying to develop what I'm going to do going forward. But I guess that for me, I think involving patients and having had an experience as a patient myself, I think trying to kind of find ways to communicate, especially kind of fundamental research to patients, is one of my. I'm about to start a new project working on pancreatic cancer, in fact, and I'd really like to try to get real, like a two-way conversation with patients about that, rather than just, I think there's a lot of, in clinical research, there's a lot of avenues already open, and actually that's not so much the case in kind of slightly less translational research. And I think as researchers, it's quite easy to lose sight of the overall picture and why you're doing what you're doing. And so I think actually trying to organize some events where researchers get to meet patients and kind of present what they're doing, and also kind of see what patients want and kind of ask good questions, because you always get loads of great questions. So that's very vague, but that's where I'd like to go with the new project that I'm working on.
And you're very rare because you were an expert in cancer before you got cancer yourself. But one of the things that we always say as people who train researchers is that once somebody is affected by a condition, they become an expert in it very, very quickly. And I think one of the important jobs for people like you is to be there with them while that's happening, because there's a lot of good information out there and there's a lot of creaky information out there, and they need a Helen with them along that journey as those sorts of things develop.
I hope so.
Who else would like to tell us about the impact they're going to have?
I don't know if it's impact, but I've got some plans for the summer, because we're about to start a new project with a partner called ArtGlow, who are based in Malawi, and they're going to be working with the mothers and the caregivers of the babies in the hospitals where we have our intervention, to kind of try and understand what their journeys have been through the healthcare system, because I think they're kind of often forgotten about. And they're going to be using techniques like participatory art and sort of photo diaries and things like that. And so one of the things I'm really going to be thinking about is I feel like I've got the confidence now and the skills to sort of think about how we're going to sort of publicize and engage with different audiences to make sure to sort of spark some kind of debate about actual patients' experiences of care in these settings. So it's really exciting. It's slightly daunting, but I'm feeling in a much better position to support that project.
Fantastic. I think the only person we haven't heard from is Reza. Is that right?
Yeah, that's right. So I'm planning to sort of disseminate our results from our work, which unfortunately has, like many other research groups, has taken a bit of a hit because of the pandemic, and give updates and where we feel that the trial with our work is going to go in terms of rolling this out to big cohorts of patients in a clinical trial, and whether, again, we're asking the right questions that patients want answered. So that's our plan, and hopefully if we get somewhere, possibly also engaging with small medium enterprises to actually potentially commercialize and get actually a product potentially to market. So that's something that, you know, the having the experience with this program is going to help with tremendously.
Wonderful. Now, the final thing that I'm going to ask all of you is about what you've learned from each other. Like, you've told me about the experts that you've met, and you've told me about the sessions you've been to and the policymakers you've talked to. And Sarah was very restrained when she met a Minister of Health. But you're also a group of people that come from very different disciplinary backgrounds, and, you know, very different career paths, very different life experiences. So I wanted to know, I wanted to get your idea. We're at the end of a session where you've been put together with a group. You've listened to each other a lot. You've given each other a lot of feedback on these talks that you gave today. And I wanted to know what you've learned from each other. And I'm going to give each of you a chance to think about that for a second while I advertise other things that are upcoming. So as Georgie said at the beginning, if you've enjoyed today, I can't invite you to another one of these events, but I can invite you to view Tuesday's event, which is available on youtube.com/scienceshowoff. If you click live, you'll find it, and will also be available in segmented parts from the UCL Institute of Healthcare Engineering's website. If you enjoy online sciencey events generally, do follow youtube.com/scienceshowoff. I've got all sorts of things coming up, some serious, some less serious, but hopefully still enjoyable. You can find details of them all at scienceshowoff.org. Now, I'm going to throw this open to all of you, and I want to know, forget the public, forget the experts you've heard from, I want to know what you've learned from each other. How much of a group have you become? Who would like to tell me first? And thus get the chance to say the most obvious thing and nobody else can say it.
Can I
Matt,
go first?
good speed, Matt, good speed.
Thank you. As soon as you said it, I kind of popped into my head that although we're all from very, very different areas of kind of academia, I suppose, there's really like that 6 degrees of separation thing, like having explored and talked to people that were actually quite a lot closer than I thought initially. For example, I think, Sarah, am I right in saying you were involved in developing the UCL Ventura device, the CPAP device that, you know, we kind of used briefly during the pandemic, and you know, Peter's involved in
Sorry,
AI.
just for viewers, what was that?
Oh, sorry. So that's that was a collaboration between the intensive care or Department of Intensive Care at UCL, and I think there was an UCL Institute of Healthcare Engineering, and I think a Formula One team at some point, to do with rapidly making a device to deliver high flow oxygen to people in respiratory failure who couldn't breathe properly just because of COVID. And that
Georgie says it's Mercedes Formula One.
Yeah. So I think there was something
UCL only deals with the luxury Formula One brand.
Yes, the top tier. Yeah, but it was an amazing collaboration that didn't actually get used very much, I don't think, in this country, but had huge impact, I think, in lower middle income countries in managing the pandemic. But
wonderful. Sorry, you were talking and I interrupted you, but only because I wanted to know more. What were the other examples you had of the 6 degrees of separations?
Oh, so the Peter using AI and machine learning, that's quite there's huge overlap with what we're doing now, specifically for kind of clinical operations management and things like that. So it's been really nice to chat with him in particular, as well as everyone else.
Fantastic, thank you. So everybody else, what have you learned from each other?
I mean, I'm actually just in awe of everybody else, to be honest, and all the things that they're doing, you know, like helping babies and survive, and helping patients in intensive care, and you know, Sarah taking ventilators to Ecuador. And I think it's been great to get to know everyone, but also I think for me, I'm very much a lab-based scientist, and who would rather not venture out of our kind of lab and microscope room. And I think to go and to meet people around UCL who are really having such an impact on health in people's everyday life has been really interesting to hear about all the research everyone's doing.
Nicely done. Now you all have to send Helen.
Yeah.
What else have you learned from each other, friends?
I was going to say, we actually haven't met in person.
I will sort that problem.
No, it's terrible,
Yeah.
isn't it? It's really bad.
It is.
We haven't actually got to sit down in a room and meet, or even stand up.
Yeah, it's been nearly a year since we started. We actually haven't met. So, despite having not met, we actually are, I would say, relatively close. Like, we've got to know each other quite well through the various number of meetings that we've had. And
it sounds like you need a picnic where you can all stay properly socially distanced outside, but still get all, was there 12 of you, 13 of you together? And Georgie, 14. Picnic is the way forward. It's the socializing event of 2021. The picnic is coming back, let me tell you. Georgie's going to organise a picnic. So Neel, you haven't met in real life, but what have you learned from everybody?
Number one is, as I think everybody's going to say, the diversity of research that we have, but also the fact that we're all at very different levels within our own career progression terms. So I'm a PhD student. We have some postdocs, we have some clinical fellows, etc. So it's good to be able to learn some of their mistakes. I don't want to say mistakes, their lessons, their teachings, so that I don't make the same mistakes in my work, which means also, I can pass them on to future people.
As a PhD student, it's good to have some friends in high places, isn't it? It's good to have some powerful, serious, long-term researcher friends that you can call on when you need them. I do a lot of teaching PhD students how to network, and the ones who are having great careers are always weirdly, randomly friends with way more powerful people than you think they should be. So schemes like this are a great way of building those links. One of them, now I can't use exact details because it would identify them, but she said she was friends with the head of a very important science at a very important science institute. And I said, how did this happen? And she said, in the summer before I started my PhD, I worked in a greengrocer's, and he used to come in every Monday and buy the same fruits and vegetables. So I got to know him. And then it turned out he was this. And I said, oh, I'm doing a PhD at your work. And so, yeah, she's on first name terms with the second most powerful researcher in this very large institute due to working in a greengrocer's. This is the sort of thing I teach in networking. Find out who everybody is. They might be useful later. For everybody else, what have you learned from each other? I know I've got a few of you to go.
I'd say resilience. I think the group has been incredibly resilient, doing something that we wouldn't have done in this way a year ago, and actually picking up new skills, not meeting face to face, not having those interactions has been incredibly challenging. But also at the same time, it's really incredible to see the levels of resilience we've all pulled, and actually learning from other people's challenges they had and how they've got around them. That's been incredibly helpful, I think.
Brilliant. Thanks, Reza.
So in my case, I am actually quite happy to meet such a variety of persons, because I see the impact that they are causing with their research, and that's really, I mean, I know that later if I want to apply for a grant, I'm pretty sure I will ask to someone in this cohort to join me for that. And I want to thank to Matt for the UCL Ventura was actually an initiative that we had with some scholars from my home country, which is Ecuador. And actually I received a lot of support from UCL. I really want to thank them, because they have been massively helpful with us in order to bring these devices to Ecuador.
I don't know if it's something that I've learned, but what I've noticed is, like, I think in the group there's been sort of like a lack of ego. It's been, I think everyone sort of approaches their work around like just wanting to do good science and wanting to help people. It sounds corny, but that's kind of what seems to be the sort of the motivation, and I find that really refreshing, because sometimes in academia, there are some big show-offs, and that hasn't been the case, and that I think that's allowed us to kind of relax into it and make mistakes and, and fluff up a bit, which is what you're supposed to do to become a better communicator. So yeah, that's been great.
Yeah, I mean, you'll definitely make a certain number of mistakes before you get really good, but it's not making the mistakes that makes you really good. This is one of the weird things I see in the startup world. People have been told that your first 5 businesses always fail, so they start 5 terrible businesses very fast just to get that out of the way, thinking that means number 6 will be successful. It's not how numbers work. Who haven't we heard from on this one yet? Peter.
Yeah, I was just going to add that I think the sort of enthusiasm, the energy that I've got from everyone else for each of these meetings that we've had, got through some pretty difficult times when you've just been on your laptop day long and your research seems kind of abstract and you're not really sure. You're so many degrees away from the actual reality of it, and hearing people talking about what they're really trying to do, all the other fellows, and the kind of purpose of their research is really motivating. So I found, just that kind of, the group has had a really positive effect on my enthusiasm for my own research.
I think that's so true. The biggest thing I've taken away from being in lockdown is, even as a freelancer, have cohorts and have teams and have new groups of people that you're doing things with. It's the only thing that's made it all bearable. Brilliant. Well, we're coming, I think, to the end of our event. We've had a wonderful time. We've learned a lot. We've met some wonderful people. I wanted to thank all of our speakers. Thanks to Reza, Sarah, Neel, Emma, Matt, Peter and Helen for appearing with me today. I've learned a lot. I've learned that urine is the window to the soul of the kidney, which is a thing that I'm going to say to sound really clever, just really out of context. So people are like, Steve knows a lot about medicine. And we're going to say goodbye to all of our wonderful speakers now, and then Georgie's going to come back and tell us how we can find out about all of the other wonderful things that the Institute does. So goodbye, speakers. Would you like to wave goodbye to all of our viewers?
Bye.
They disappear one by one because that's how StreamYard works. And then bring Georgie back. Georgie, how can people find out more about all of the other incredible projects that your Institute's creating?
Firstly, big thank you to you, and big thank you to all the speakers, all of our wonderful fellows. It's been such an incredible year with you all, and your talks were brilliant. Even though I'm, hearing them all for the nth time now. In terms of other things that we do with the Institute of Healthcare Engineering, there's loads and loads and loads of information on our Twitter. Steve, can you do that thing where you? There we go. So health_eng. That's our Twitter. I'm going to post a link on there as well, a sign-up link for our newsletter, and that will keep you updated. It goes out once a month. It's not spammy at all, but that will tell you about other events we have coming up, lots of other things that we do that's not in the engagement sphere, so different things to this. And it will also tell you about the Impact Fellowship Scheme. So the applications for that, again, will go live next September. Hopefully that's given you a bit of a flavour for it, but it's a really cool thing to be part of, and you'll get to spend a lot of time with me. So go for it.
Absolutely wonderful. Thank you all so very much for watching. You can find Georgie's team online at @health_ENG. If you want to chat to me, I'm @Steve_ and then the letter X, as if I was signing off an email to you with an inappropriate kiss. It's been great fun talking to all of you. Have a brilliant day, and go and look all of our speakers up and find out what they do next. Bye.